And today we've got a great lineup of speakers. And but before we kind of like launch into that, I'm going to do a little bit of introductions. Today we're talking about kind of our ethical obligations in reopening the community. So this is kind of as we move into kind of the second phase of addressing the pandemic in Kansas City. We're going to talk about kind of our ethical obligations in helping vulnerable communities and just making sure that we kind of go about this the right way. So starting out, we've got our series of panelists here. First, we're going to hear from Melissa Robinson, who's the 3rd District Councilwoman and President of the Black Healthcare Coalition. Shortly after that, we'll hear from Erica Andrade, the Chief Program Officer at El Centro. And then I'm going to hand it off to Jannette Berkley-Patton, who is a professor in the Department of Biomedical and Health Informatics at UMKC School of Medicine. And finally, I'll hand it off to Deacon, who's the Managing Director of Kansas City Digital Drive, to tell us about some of the community efforts. But to set the table, first I'd like to talk just a tiny bit about testing, tracing, and supported isolation plans. So these are basically, this is kind of a general version of, or a way to sort of like generally refer to the types of plans that are being used kind of all over the country as we start talking about reopening the economy. The phrase testing, tracing, and supported isolation is kind of how the Edmund J. Safra Center for Ethics at Harvard described their plan, which is called the Roadmap to Pandemic Resilience. So this is kind of the way that they've thought about sort of like once you've reached the point where you need to kind of like take a next step from just social distancing and social isolation, kind of like the lockdown circumstances, what does a sort of like a deliberate strategy in reopening look like? And there's like these 3 major components, which is to massively scale up your testing capacity, and then implement some type of technology-assisted contact tracing program, and then feed the results of those 2 things into some type of supported isolation program. Kind of critically here, when we're talking about these types of plans, like the amount of testing that you need to be doing, the important thing to know about the amount of testing you need to be doing is it's not just to determine if individuals have contracted the virus. You have to have a kind of a population or a population scale picture of kind of how widely the virus has spread, and you need to be relatively confident that you're catching most of the cases. The technology-assisted contact tracing is what then helps you make this kind of this right side cut, the one step ahead cut, which allows you to get people into isolation so that they don't spread the infection further. Finally, there's this element of supported isolation. This is something that I think is maybe not talked about quite enough, and hopefully something we can talk about a little bit today. And that's that particularly with people who have been exposed and need to go into isolation. It's difficult to just sort of tell them to like go home and shut the doors. We need to be thinking about some type of cohesive community response to enable them to remain isolated while they wait out the infection. So that's kind of like, I think the premise of most of these reopening plans. Kansas City has a plan that's been kind of talked about here and there, and something that we're going to talk about more particularly today. I just wanted to make sure that we kind of had this as our sort of springboard for having this conversation. And so with that, I would like to hand it off to our first panelist to kind of introduce herself and talk about her work and her concerns today, and that's Melissa Robinson. So Melissa, would you like to take it away?
Absolutely. Thank you so much to the Center for Practical Bioethics for hosting this real point in time information opportunity for people to connect, listen, and share I'm thankful to all of you out there that are participating and sharing your lunch hour with us today. Again, my name is Melissa Robinson, and I serve as the 3rd District City Council person. I'm an in-district representative, which means that my sole focus is on approximately 70,000 of our residents in the city of Kansas City. The rough boundaries include Independence Avenue to Brush Creek, Truce over to the Arrowhead Stadium. Our district has some specific unique dynamics, as all of the council districts do, in that we have the most economically insecure individuals that are there, and then we're also the most racially diverse as it relates to looking at immigrant communities and the African American community as well. We have been disproportionately impacted by COVID-19 because of the economic insecurity. And so the testing and the impacts have hit us in a way that we have to respond differently. So what I'm most concerned about as it relates to reopening and as it relates to how do we do that in an ethical way, I believe that from an ethical perspective, it's important for city leaders, especially politicians, not to put politics over the interests of the productivity, the health and safety of people. And Kansas City, in this particular dynamic, we are considered a small city. So when you talk about the CARES Act and the funding that is available for COVID relief, that is available for testing and tracing that you talked about, so that we can adequately deploy this so everyone has access to testing and tracing and resources. The city has to go through Jackson County, because we have less than 500,000 people, to access those funds directly. So from an ethical perspective, it's really important that we work collaboratively with our county to ensure that we're not stifling and behind the curve, as we currently are behind the curve as it relates to testing and tracing. So I'm extremely concerned about that. I am advocating for us, again, to work collaboratively to address those things. The other things that we have to think about when you talk about supported isolation or our homeless individuals, if you will. And so the city of Kansas City, we have invested in a cooperative agreement with our local hotels and ensuring that we're paying for those room nights for individuals who are not only positive, but are impacted by COVID-19. I am also concerned, again, I cannot underscore this enough, and I will allow Aaron Deacon to talk more about the regional efforts related to testing, but I can't underscore enough the importance of testing in the right areas. When we start to open back up, we need to think about it from an equity approach as it relates to those who are those continual essential workers, and ensuring that testing, that we're selecting those sites based on individuals' potential exposure, and that we're providing asymptomatic testing. The city, for all intents and purposes, has not started asymptomatic testing until last week. So we're extremely behind. And I am also finally, and I'll allow for others to give their introduction, but the 3rd District has also the most economically fragile business-based economy in the city. And so how do we address our small businesses, our social service providers, our faith-based communities who have not been open, but our faith-based centers are the most well-kept and social serving organization asset in the 3rd District. So I'm very concerned about some of the populations that often do not get talked about and discussed. Thank you.
All right, thank you, Melissa. And next I'd like to go to Erica Andrade of El Centro. Erica, can you tell us a little bit about El Centro and the work they're doing?
Sure. Erica Andrade, Chief Program Officer with El Centro. El Centro is a nonprofit agency in Kansas City, Kansas. We have a satellite site in Olathe, Kansas. We serve primarily the state of Kansas, this side of the state line. We've been around for 43 years, and we do a variety of different social services, but our target population is Latino, mostly new immigrant, mixed status households, primarily Spanish-speaking individuals. And so some of, obviously, we firsthand see how this pandemic has disproportionately affected the people that we serve in ways that is maybe different than in other areas. It's kind of twofold. So we have a lot of our population that is finding themselves out of work and unable to access some of those stimulus packages or those resources that other individuals are able to have access to. And then at the same time, we have a large part of our population that is out there still working on the front line as essential workers. So we see both of those things happening at the same time. So we definitely think that testing is really important, but also understanding that as we promote testing, we also have to open it up with the asymptomatic testing. That has to be, has to start happening a lot more. But then also what happens after? There's a big fear of, if I get tested, it's going to come up positive, then I can't work. How am I going to survive? So there's a lot of that fear behind that as well. So we have to be able to talk about the importance of the testing, but also what happens after. Also the communication and technology difficulties that we have with our community when trying to register or trying to call for information on resources and things like that is also a big barrier. We've had to take to social media to get a lot of information out, obviously because we have to limit our one-on-one exposure with the community. And so a lot of the services that we do have kind of changed a little. We had to kind of take heed from what we were listening from the community. We started doing drive-through grocery giveaways every Thursdays, both in KCK and in Olathe, because it was something that our community was asking for, that they were needing assistance with both, those kind of like needed necessities, the food, the utility, the rent, even though that they had those laws in place so that you can't turn off utilities and rent, you still can't come out of this with 3 months back bills, you're going to get shut off. So just a lot of that kind of communication and understanding that the communities that I'm representing within Centro are communities that are not being able to access a lot of these kind of support services and things like that. And so they're in an even more vulnerable population than others.
All right, thank you, Erica. Next, I'd like to pass it off to Jannette Berkley-Patton, who's going to tell us a little bit about her work and some of her top line concerns as we talk about reopening. Oh, I think you're still on mute, actually.
Thank you, and thank you for giving me an opportunity to be a part of this panel. The work that I do at UMKC in the School of Medicine is primarily focused on health disparities and health disparities research. We work with many of our urban Kansas City community-based organizations, and particularly in the African American faith community. We also do a lot of work with youth organizations. And in doing so, one of the things that we really strive to do as an approach is to make sure that we engage our community partners in every single phase of our research. And that includes, how do you communicate health messaging? And so with COVID-19, one of my concerns is, how are we packaging the messaging around prevention, around protections, and around testing and supportive isolation? And who are we going to and including in the conversations about how that messaging is shaped, what outlets it needs to go through, and whether or not the messaging is landing. And to do that, we really need to be able to be sure that the appropriate relationships are being built for, particularly when it comes to health messaging and something that's new. I mean, COVID-19 kind of came out of nowhere for everyone. There can be issues around mistrust about health information that lands in the community and who's communicating that information. And so to build trust, we need to make sure that we are including community partners in every single phase of rollout, from testing, even including how we're going to make plans for the vaccine that's supposed to be coming. Because if we could start getting community members together now and community organizations together now on what strategies will work best for them, we'll be better prepared in the future. You would have thought that we would have learned from other things that have come our way and hit hard in communities of color, like Hurricane Katrina, like HIV. issues that really took understanding the community and having the community voice be a part of solving the problem. And I think that's needed here as well.
All right, thank you, Jeannette. And finally, for our introductions and kind of table setting, I'd like to talk to Aaron Deacon a little bit about some of the community efforts going on.
Yeah, thanks, Matthew. It's a pleasure to be on this panel with all of you today. It's a little bit maybe of an odd fit for us, KC Digital Drive, which is sort of a technology-focused nonprofit organization, to be doing some of the things that we're doing. But I think it's interesting and works for a couple of reasons. Even though you've talked a little bit about the technology piece around contact tracing, and there's some kind of real technology pieces that fit into this plan. But it's really not a technology issue. It's not a technology plan. It's a small role. But what it does have, and what we've seen, is that there is a lot of unknowns. It's new information. It's poorly understood, and it is pretty dynamic. And that is something that is true of a lot of the work that we do with emerging tech. So we've got a lot of experience working in sort of confusing information environments with a lot of new info and rapid information change. And then the second piece that we typically do from a tech perspective is think about how does that affect different kinds of populations within the community, and how do we make sure that emerging technology, what we usually focus on, both doesn't have unintended consequences and is used in a way that can support equitable solutions and interface with our existing infrastructure, in meaningful and positive ways. Well, we see a lot of that same need in this COVID context. So we've been working, really to develop a regional testing, tracing, supporting self-isolation plan with, both the local governments and the health officials that represent the governments, the private sector, through a group of ad hoc corporate CEOs who had just jumped in and started buying equipment and tests where they saw gaps, as well as the more formal channels like the Civic Council and the Chamber of Commerce and the KCADC, working closely with Mid-America Regional Council and the funding community, but also doing neighborhood outreach, through the Center for Neighborhoods and Livable Neighborhoods at UMKC and the Unified Government, respectively, and really trying to figure out, as we do these plans, how do we think about the regional systems approach. And it's tricky because the reality is you've got CARES Act funding that goes through 2 counties. You've got the rest of the counties that are getting funding directly from the state, which gets the federal funding. You've got the KCMO population issue that Melissa mentioned, and you've got different public health authorities in 6 or 10 different counties, depending on how you want to draw the lines, that all have their own responsibility. And that's just from a public health standpoint. Then you've got businesses reopening, and you've got all the other services that people are supposed to be delivering, and you've got businesses that are closing down, and you have people that need all the things they already needed. I saw Betty's comment in the chat about dialysis, right, which is not something that's on the radar necessarily of a COVID response plan, but the reality is you've got patients that need dialysis all over the metro, and this is impacting how we can deliver that service. So, how we truly develop a regional systems approach that allows us to allocate resources efficiently, because this is a regional problem, even though we don't quite have the mechanisms set up to do that, is really part of the challenge. And it's, there's a real ethical dimension to how we do that, both in a way that allows us to address the problem equitably, to use our resources in an equitable way, and also that is respectful of the fact that people have legitimate differences in what they think needs to be done and how they would approach it, and the science on all of this is still developing. So as much as we try to be science driven, I think, and data driven in how we approach things, even that landscape is pretty fluid. And I think then the other kind of element to how we think about actually implementing and funding that is, what is the right mix of the private and public and philanthropic sector? We know that there's a lot of federal money that flows down through these different channels. The philanthropic sector has stepped up in a huge way, and put money into the recovery fund, and I think you can say the same for the private sector, but we've really got to do a good job of understanding what's sort of the full landscape of needs. Where do we have money that is allocated and earmarked? But then what are those gaps, and how do we really focus on the equity considerations in filling those gaps, when it comes to things like you were talking about at the beginning, Matthew, with supporting self-isolation. And if we're going to be asking people to take, certain steps for the good of the community, how do we put the structures in place to support that, just from a systems and operations standpoint, but also from a funding and making it actually happen, sort of beyond the theory.
Excellent. Thanks, Aaron. All right, and it looks like we've already got a couple of questions coming in. Melissa's already answered one of them or responded to one of them in the chat, kind of around transportation resources and working with FQHCs. Kind of to follow on to Aaron's point, we have a question here from John. It says, it sounds like you're all in agreement how important it is to involve organizations that are really the boots on the ground, but almost sounds overwhelming in terms of how to coordinate it all. Do you have any specific ideas on how to herd these cats? Like facing issues of siloing and information flows. Melissa, do you want to take that one to begin with?
Sure. I think it's an excellent question, and I believe the answer really lies in our ability to apply basic leadership principles. This is about leadership. We have an enormous amount of resources that are available to us in the region. Aaron Deacon is leading an effort that is tremendous as it relates to providing us the technical assistance needed to deploy what we need in order to be successful and to beat COVID. Leadership is about disappointing others at the rate that they can tolerate, right? That's important. And leadership is about doing what's necessary to move the agenda forward. So if we can take a moment to think about for ourselves, how do we lean into that and say, how can I contribute to move this agenda forward? And not necessarily talk about, yes, we need money and we need resources, but what is the outcome that we're trying to all achieve? And focus on what we need to do versus who's going to get what to do it. That is, unfortunately, it's a paradigm shift, especially in the political realm and nature of things. And the politicians are really we're the ones who are either have the money or fighting for the money. And that's something that we need to cease immediately if we're going to come out of this stronger.
All right, thanks. Do we have another additional response to that?
Sure. I would say that my thought is, I think it's really important that when they're doing the testing sites and things like people like the entities like the health department and even safety net clinics, when they're planning out their kind of push of how they're going to get this testing done, they really do need to partner with community organizations. This can be either churches, community centers, or other already established nonprofits, because they're the ones that are going to have that trusted message for the community that they're trying to come in to get tested. Just the health departments working with safety net clinics is not enough. They're not getting enough numbers out there for people to come in and get registered and get tested. Also, the registration processes need to get a lot more accessible. I understand that we need to have information so that we can do the tracing and the tracking, and that's important, but you have to allow for people to just drive in without a registration and get their test done, because a lot of times it's somebody that's driving by, sees it, and it's like, yeah, I should get tested, and stops by it, because we know that that's how people's living their day-to-day lives. You can't do a registration and then call somebody, tell them that next week at 2 o'clock you're going to go and get tested. Things happen and come up, and you're losing a lot of people from registrations like that. So that's another thing to keep into mind. And that's one thing that community groups, churches, safety net clinic, nonprofits and things, we know about being flexible. You got to kind of roll with the punches. You got to go with where the community is, because that's how you're going to get them tested.
Yeah, and I think, to Melissa's point, I mean, there's only so much you can do about politics, and we try to not get too much in the middle of that. I think one of the things that the community groups can do, and that we've kind of taken the approach of, is to help provide the politicians cover in some ways. So it's one thing, if a mayor tells somebody to do something, or a governor issues an order, but we need those same orders, might not be the right word, but all of these decisions are, need to be sort of supported from multiple sources of trust. And I think that's really where those faith communities come in, those community groups, and so we need to have, I think, a really well-rounded approach to how we think about this as a community problem. This isn't just something that the government's going to solve, although it has a huge role and obviously controls a bunch of purse strings. But we really need to kind of rally support from a lot of different sources, and your neighbors and your family and your friends. And I think the other piece of that, from a kind of a strategy standpoint, is we've got both an operational piece and the messaging piece. And it's tough to align them because they're both being created sort of at the same time. And so, we've talked some about testing and asymptomatic testing and getting people, so there's one piece of that. It's just making sure we actually have the tests available, and we have places that people can go, and we have, systems set up to take them in at the right time. And so you don't want to go have messaging that says, hey, go get tested. We need to get tested. We need asymptomatic testing, if we don't actually have the pieces in place to do it. But at the same time, we want to start sharing those messages out there. So, we're trying to, I think, build them both at the same time. And it really involves, I think, a lot of close coordination between kind of that operational strategy development and that messaging and engagement piece to make it really work.
I would just comment and add to that, particularly on the engagement piece, that as our city really works on its responder plan, that it really needs to take into consideration many of these different organizations who are taking the matter into their own hands because they don't have enough direction and planning how they're interpreting and rolling out their reopening guidelines. So for instance, I've been working with African-American faith communities and leaders because they're really concerned about how do they reopen their churches. And I do have to say that for the ones that we've been working with, they are not in a rush. They're not in a hurry to bring people back into churches and, be a potential site to spread the virus. And so we've been working with them on taking the orders that have been given and then trying to come up with practical ways that make sense for their setting and that are cost effective as well, so that they can open safely when they're ready, and do it in a way that their members feel like, their health is being protected. And the same also, I'll comment too, and the same with youth organizations. We have a group of leaders from youth organizations that are trying to do the same and trying to figure out how can we give youth what they want, but also educate them on what are safe practices. And so all of those strategies need to be tailored for very different specific groups. It's not a one plan works for all, you know what I mean? The plan has to make sense for each group and in context for the setting as well.
Yeah. Something that I think that this kind of dovetails into a little bit is sort of how this focus has been placed on, the focus has been placed on testing and tracing so far. And something that I want to make sure to touch on today is kind of what we think the critical elements of supported isolation would look like. I think I'd like to maybe start with Erica on this one. Just when we're talking about supported isolation and what happens when we have people who are found to either have been exposed or test positive. What are the, at least with respect to the communities that you work with, what does supported isolation actually look like in real terms?
Yeah, it would include a lot of different levels of things. Obviously, you go with the bare necessities in the beginning, which is food, access to food, and then having somebody be able to bring it to their home and drop off the food that they're going to need, things like that, so they're not going out outside once they're in quarantine. And then also, though, if they're a sole primary income winner, and then also they don't qualify for unemployment and things like that, then how are they supposed to, you know, pay rent that month if, you know, half of the month they were in isolation? And that's if they were asymptomatic and didn't get sick. You know, what happens to medical bills? Will they get access to the same medical treatment if they don't have insurance? That's another big question that comes up. I know that we've heard that they'll treat everybody, but do they really treat everybody? That's a question that keeps coming up. You know, because I'm sorry, but hospital policies around here have been getting from bad to worse over the last few years as far as who they treat when they're uninsured and uninsurable, which is a bigger point. So, you know, so those kind of things are things that people are very afraid of, and they have a right to be afraid of those things. And so they're going to need support services when it comes to those, both from utility, rental assistance, food assistance, to are they going to get the medical care that they need?
Yeah, I think that's a tough set of questions, because it's requires a significant sort of material lift. Something that we just got that kind of keys back into this question about communication, coming in from Deborah. She's actually a manager of patient engagement at Truman, and was asking how she'd like to hear how people think that communication is going so far, and what suggestions you could have for us to work in coordinating that manner on messaging as information continues to become available, and suggested behaviors need to adapt to this learning.
So I can take a shot at that, and also, Deb, issue an invitation. I mean, we've got, so from a campaign perspective, we put up a site called Comeback KC, I think it's .com, and have started collecting from a lot of the public health officials, but also some other medical professionals, what the key messages are. And so there's work creating infographics and you know, some short kind of 1-minute explainer videos. To your question of how good of it, I don't know that we've done a great job. I think it's confusing. It's a pretty evolving landscape, and we've heard this from some of the community people that we've talked to. And I think there's a whole other set of communications. I mean, you hear a lot about washing hands and, you know, stay at home if you can, but also what does that really mean? You know, stay at home if you can. I mean, I've got 4 kids, 2 teenagers who are like, hey, can I go play football at the park? Can we have people around the bonfire in the backyard? Can I go over and have an outdoor dinner? You know, and you've got people all over the place that are kind of thinking, okay, what am I actually going to do? You know, just in my life and with my family. And I don't know that there's clear messaging for that. So, you know, that's part of the kind of, you know, what is a personal safe reopening guide we have some people working on, but the ask would be, we're definitely looking to, you know, create a pool of medical advisors or healthcare professionals who can feed into that. So, you know, one, that we've got a diverse set of voices that help to craft that messaging. But then also, you know, how do we get those messages out, and what are the right channels to make sure that gets to different communities? How are those, you know, messages going to be received? What do different kinds of people need to hear? You know, we know that's critical, and we've got a lot of volunteers from the AIGA, which is the local, you know, a local design group that are willing to do some of these, you know, create some of these pieces. But we need to make sure that they're the right messages that get out, and that they get out in the right way. So would invite participation. Feel free, anyone, to email me if you want to get closer to that effort.
Great. I've got another one here. This one I'd like to ask Jeannette. In a recent piece for KCUR, you spoke about the importance of providing public health data to community leaders. That's something that I think is a really interesting notion. Can you talk a little bit about kind of what types of data, or what data can do to empower community leaders, and what types of resources they might find most useful?
Sure. I mean, certainly the most important data to get out is on the number of cases and where the cases are being found. to be able to convey that information in a way that's digestible to community leaders is really, really important. Because data is only as good as it is understandable and as it is actionable. And so some of the strategies that Aaron had mentioned, like using infographics and short videos and making sure that they're tailored for different groups of folks, are really important for that. But along with that, in knowing like where the new cases coming and where are people dying from COVID-19, we also need to have more data around what are some of those chronic diseases that make populations vulnerable. So more location-based information about, where are the hot spots around diabetes and heart disease and other chronic diseases that are prevalent in communities of color. And then we also need to make sure that we're sharing some of the successes as well. You know what I mean? What's going well? We can't always focus on what's not going right, but we need to focus on what's going well and who's doing what. And I think that's a really important thing because there are so many people, so many organizations doing so many things to try to help out in some kind of way in the community. And I think it's somewhat fragmented so that the right hand doesn't know what the left hand is doing. And so if there was a way to be able to share more information about what organization is doing what so that we can understand where the gaps are and understand where the needs are and be able to move resources to the needs, I think that would be really, really helpful. And then it goes back to, again, asking communities, what information do you need? What information is compelling with the groups that you work with? And how does that need to be packaged? And which outlets does that information need to flow through will be really, really important.
So really looking for like a full feedback loop, like requests and answers. Yeah. Interesting.
Yes.
All right, I've got another one I'd like to hand to Melissa. Kind of one of the critical questions and discussions about reopening is how we're balancing the risks of illness against the material needs of workers and their families. Can you talk a little bit about these challenges and how different stakeholders are thinking about them and as we move forward?
Yes, and so I currently don't have a role as it relates to what those discussions are. We know that our public health officials have really talked about a reopening plan that ensures that our hospital systems, and especially those systems that also provide indigent care, are adequately capacitated to be able to handle illness. So that is one of the dynamics in which, in thinking about reopening, how are we going to be able to take care of people who are ill, and do we have what we need in order to take care of them? How many hospital beds do we have? And so it is a critical point. I was just wanting to respond to Betty Bloom, her comment regarding, again, dialysis and transportation. And she made a specific, more descriptor around a rural community clinic. One of the things you might consider if you don't have a strong transportation network where you are is making sure that your patients have access to multiple masks and that they can offer those to the drivers so that when they're, because we don't know if the drivers want to wear them or don't have them. And so that could be made available to the drivers, not making them do it, but as a resource that you give to your patients.
Good tip. All right, I've got another one for Erica. You've talked a little bit about this already, and this is kind of consonant with one of the sort of themes that's emerging here is the importance of strong communication and interinstitutional communication. And you've talked a little bit about language barriers and some of the issues facing the communities that you work with. So can you talk a little bit more about kind of like the types of like what sorts of challenges these pose and the ways that we could theoretically address them?
Sure. For the language barriers in particular, and it doesn't matter what's the primary language of the household, if it's not English, then there's already going to be a struggle when it comes to registration or finding the information of where to go, those kind of things. Usually things you can find, especially if they're put out by the county, you usually find them in English and Spanish, but other languages, then they get a little harder. But then also it comes to the registration process, which a lot of places for testing and even tracking are using apps, you know, and it's easy for me, for somebody like me, you know, I love it, you know, it's fast, I get my phone, you know, smartphones can get you with anything. But the issue comes in with, even when they're very well translated, the actual registration piece, the information that you're putting in, the apps themselves don't translate. So in order to go to the next screen or submit, those buttons still stay always in English. So even if I'm understanding that it's asking for my name, my nombre, and I'm getting through that screen, then to get to the next one, I get a little lost. I can get a little lost because the actual framework of the apps don't change. So that's an issue to think of, you know, when you're thinking about these things. Also, when you're getting replies. So if you go to one of the testing sites and it's time to get your call back, to get your results, and then also if you're going to be doing tracking, you have to have enough personnel that's going to be able to do that work in the language that's appropriate to the person that you're talking to. And I know that it can get expensive, and then also trying to find the right people and hire the right people that are fluent in the language. So those are all things that just need to be considered, because the more you start testing, the more these issues will come up when we have a diverse population like we do, especially in Wyandotte County, which has a very diverse population. So we need to make sure that we're going to be able to provide the access, and then also the resources and the languages that are needed. And to keep those things in mind when you're looking at something, when you think it's very easy to access, but it might not be to others. Also with technology, you know, you're talking about bandwidth, and you're talking about data minutes and things like that. And do they have access to be able to do these kind of things?
Yeah, and that's actually something I'd like to talk to Aaron about a little bit. Insofar as he's our resident technologist. One of the concerns that I hear kind of coming up around TTSI plans and their reliance on I guess to the extent that they rely on like smartphone applications and stuff like that, is the worry that these kinds of things can kind of deepen iniquities along the digital divide, right? People who have access and people who don't, and I think that's particularly of interest in a situation where like the most vulnerable community might also be the one that has limited access, right? So can you talk a little bit about some of those concerns and how plans can, or how TTSI plans can adapt to them?
Yeah, for sure. And I think it's really important. I'd say the first thing is that and I kind of referenced this at the beginning, the tech really needs to fit into a large scale plan. So I think it can add some efficiencies to the system. It's not going to solve, you know, if you look at contact tracing, and there's been a lot of, you know, ink on contact tracing apps and what they can do and what they can't and what that even means. You know, we still really think we need manual contact tracing forces, and that there are ways for the tech to make that more efficient. And really, I think, you know, we know there's going to be some populations with phones and without them. Some, you know, to the language barrier question, that's going to be an issue in some cases. And I think the hope is, if we're using those technologies to make the manual resources that we're hiring more efficient, and we can, you know, say take a contact tracing call with somebody that has a phone and an app, you know, maybe from 45 minutes down to 30 minutes. I don't know if that's right, but, you know, then those tracers have more time to spend with the people who are going to need more time. And that's what we see. I mean, I think a lot of when we talk about, you know, vulnerable communities and providing social services across the range of things that are needed, it's time intensive. It's human touch work. It's sitting down with the person and helping walk through things. And we're in a resource constrained environment. So if we make sure that we use the gains and efficiency that we can get through some technology to use that, the extra time that frees up to devote that to addressing inequities, I think that's a big part of the opportunity.
All right, thank you. And Melissa, did you have something you wanted to say there?
Oh, no, I'm sorry. I just
Okay.
forgot to put my.
You're right. I just saw it off mute, so I didn't want to cut you off. All right, so I've got another one coming in from an audience member here. This is kind of a technical question, so we may or may not have the data for it, but this is, what is the current availability of adequate tests across the bi-state area that is needed to move some of these plans forward? I know this is a little bit of a moving target. I think depending on kind of, at least the stuff that I've been following along, I know that 3,000 was a number that, like 3,000 daily was a number that was thrown around for a while. I think there are some concerns that that might need to be sort of a floor that we build up from. Are there anyone who wants to jump in on that as well?
I can talk about some of the efforts, and I know Aaron has more of the science behind where we are and collecting data and trying to get us up to the 3,000, but it's more about like who is doing what rather than like being able to track exactly how many tests are being done, at least from my perspective. And that is, we know that KU is in a research study in which they are deploying free asymptomatic tests. However, when you're talking about research studies, there is a level of rigidity that comes with that. And Erica pointed out some of the challenges that may or may not be happening with that particular study. But the question is, how much testing is happening. So they have a great capacity to test people through community-based organizations. I am still trying to get more information regarding their research questions that they're asking, because again, that might be a challenge or barrier for people when they're not familiar with participatory research and how that translates. That's an effort that's going on that's by state. On the Missouri side, we have, and this is throughout several counties in Missouri, we have the Kansas City Health Department that is doing health testing, and they do provide drive-through testing. You don't need to make an appointment. There is some challenges as the wait time, because you have lines wrapped around buildings and through traffic of people waiting to be tested. They have 3 providers that are doing that testing. Because I led the effort to get the funding, I know that they have about $695,000 worth of testing that's happening through that effort. And then you have Truman Medical Center that picks up Eastern Jackson County as well as Jackson County at large, and they're doing only symptomatic testing. So those are the 3 efforts. The state of Missouri is also doing testing. I don't know, Aaron may have more information about the state of Missouri and how they've deployed testing as well. But those are the initiatives that I'm aware of. But with all of that, we are woefully low. And we're working with Aaron to deploy in Jackson County 1,800 tests a day over the next 30 days.
And I just say I don't have the details at my fingertips. I would say when we project over the next few months what we need, we don't have the resources. We can get there, and so I think part, especially from a supply standpoint, we know how to get them. We know that there's money there. A lot of this is just putting the pieces together and getting it done. And it's frustrating sometimes that it doesn't happen as readily as you'd think. But I think as we do get up there in terms of having the supplies available and the ability to do asymptomatic testing, I do think the next challenge, and this is kind of to that operational messaging building side by side, is going to be getting people to go get them. We heard from Wyandotte County several weeks ago that they had a bunch of tests, and they even had capacity to do a couple hundred a day, and they were maybe getting 30 or 40 people to show up. Part of that is you don't know where to go, and you don't know if you're eligible, but also part of it is people don't like having something stuck up their nose, and it's not the most comfortable thing, and sometimes there's trust issues about what's happening to the data and what kind of data do you need to share to get your test? So that goes back to that, you know, the messaging piece. I think we'll get to a point where we've got the supplies in place, and then people are going to look around and be like, oh, well, we just spent all this money, we got all these tests, but now nobody's getting them. What's wrong? So there's a demand side of getting to 3,000 a day that is going to be a trickier problem, maybe even than the supply side.
Well, and if I can add one thing, because this panel is about ethics, right, in reopening, and there's a real ethical challenge around making you jump through all of these hoops and provide all of this information in order to get a test, you know? And so to the extent that we can apply pressure to make sure that everyone has access to testing and they don't have to, you know, do all of these things in order to get attested, I mean, it's a real challenge. And so we're trying to work through some of those things and trying to figure out a way, and Jannette Berkley-Patton can talk more about this, but figure out a way, how do we balance the community voice when we have access to these resources, especially in the research environment, to make sure that people are not being in this place where they feel manipulated or they feel like they're having to do all this extra stuff in order to get something that should be so simple and open for everyone.
Yeah, I mean, I agree. I mean, it's kind of reminding me back when HIV testing became more ubiquitous, and there was a need to make sure that people could get it, that, again, they wouldn't have to jump through a lot of hoops to get it, and that the test results would not discriminate them in some kind of way, because COVID has its own stigmas that are being attached to it. And it's some of the, we're starting to launch a couple of studies to try to understand stigma, to try to understand behaviors, and try to understand attitudes about the virus, so that, you know, in the near future, we can plan appropriately and how do we address testing, and especially when testing is going to be more open and more available. And when antibody testing becomes more available, and again, when vaccines become more available, how can we make sure that the demand is there, but that also people don't feel like there's this mistrust because they don't understand where their information is going to go and how it's going to be used. In the approaches that we've used, particularly in the faith community around HIV testing, that has worked incredibly well, is to engage our faith leaders in promoting testing and encourage them to model the behavior. And so that's getting a test in front of their congregants. In this case, it would be getting a test for COVID-19 in front of their congregants, in front of the community members that they serve. And also in modeling those protective behaviors like wearing a mask, so that, you know, again, beginning to normalize testing and the preventative behavior that needs to be in place. But again, as long as it has many hoops and obstacles to jump through, if people are having difficulties, this is one other thing that we've learned, if people are having difficulties getting their results as well, and we know that that's been the case for some, people communicate with each other, and that just dissuades more and more people not to try to go through that process. So we have to make the process simple. It has to be accessible. We have to have the right positive messaging around it and how it benefits the community overall. And we have to make sure that people know that they are safe, that it's a trusted process.
I think that that's a great point for us to kind of wrap this up on as we come up on 1 o'clock. I think that the role of trust and kind of community engagement in the building of trust, I think, is going to be an absolutely imperative part of moving forward. We had one more question came in, which I'll reference here kind of in this context, and that's the issue of giving out so much information regarding tracking and being able to trust that information will be secure and safe, and so like I think along a lot of these axes, I mean, to the extent that we talk about this issue as something that has to be collaborative with lots of different organizations working together, trust is going to be an absolutely imperative resource that we have to cultivate and collect over time. So with that, I would just like to wrap it up and say thank you so much to all of our panelists today. This has been an excellent program. Thank you for taking your time to contribute. And just as a kind of a follow-up, these sessions are recorded and we post them to our YouTube channel. So if you want to review any of the content we talked about today, or send this on to any of your colleagues who weren't able to tune in, please feel free to do that. You can find it at Practical Bioethics on YouTube, and then also on our webpage, practicalbioethics.org. My name is Matthew Piecha, and this has been the Ethics Committee Consortium webinar series. Thanks again to Jeannette, Erica, Melissa, and Aaron, and we will catch you next time.